In this episode of Vital Conversations, a Doc Talk community series, Dr. Stephen Tamang talks with Monument Health CEO Paulette Davidson about the future of healthcare in Western South Dakota, from insurance barriers and Medicaid concerns to AI in medicine and Native American health disparities. A candid, thoughtful look at how leadership, innovation, and compassion shape community care. It's coming up on Vital Conversations.
Paulette, thank you so much for coming on. It's so exciting to get to talk to you, and I have a ton of stuff that I think people are very interested in. For our patients, I think one of the big topics is their relationship with their physician, APP, and how the health insurance industry affects that.
Yeah.
A lot of people feel like it interferes, and a lot of people feel like their coverage is actually dictating the medical care that they get. And so my question is, how do we protect our patients?
Yeah, it's a challenge. Absolutely. I think, in my role, I'm trying to increase access to care, meaning I'm trying to reduce barriers for our families, people living in our communities that want to get in to see their doctor, to see their practitioner, and to reduce the friction. We're all used to having more convenience in scheduling different types of appointments, maybe booking an airline ticket or even booking your car for an oil change. It's easier. And that's the same path that we're trying to create for our patients, our families, to get in to see their doctor. And so, when you have this extra barrier or a gatekeeper, an insurance plan or an insurance company, that you have to find permission or get permission first to see a doctor, that's, I think that causes friction. And, how do we work with that? Absolutely.
Yes. And I don't want it to be self-promoting to Monument Health, but I am pleased from the physician side that the financial piece has never been a barrier for someone coming in to see us.
Yeah.
Things get sorted on the back end, but it causes a lot of problems from an operational perspective. And it's really become sort of a touch point in really across the country. I'm sure you were aware, I think back in December, when that tragic event occurred with Luigi Mangione, with the allegedly the perpetrator of the assassination of Brian Thompson.
Yes.
I think we were all aghast by that, but I think what was shocking was that there was actually a fair amount of public, I don't know if I want to say support, but there was a feeling that some people felt that this was in some way justified, which is a very terrifying thought. As someone who's obviously involved in the healthcare system level, that's deeply involved with the insurance world, what was your take on that whole process?
Well, I think I was like everyone else. I was shocked. At first when the murder happened, you didn't know enough about who did it or who allegedly was involved. More's come to light. And, I think, we'll let the court system address what really took place. But I think it's, as you mentioned, the public sentiment around the event really just increased the focus on what was happening or has started to happen more often between a person and their insurance plan. And it's that friction. It's the approvals, the pre-authorizations that people have to go through the process to get, say, an imaging test or a surgical procedure approved. It's taking, for example, in many of our areas across our health system, it's taking weeks to get those approvals. And people are waiting, or they're having to go through what's called step therapy with drugs. They have to try a certain drug first to see if it's effective before they move on to a different drug, which might be more expensive. And so those are those pre-authorizations that are taking place. But on the back end, after care is delivered, And we're seeing it in our organization. We're seeing insurance plans denying the claim. They're denying the claim because a code was improperly used, or they're saying insufficient information was provided to the insurance plan, or it's as little as, I'm calling it a syntax error. It's not a clean claim, and it bounces back. And I think what we're finding is that the rules for filing claims are becoming more difficult. They're changing quite often, and it's very difficult for even us as a health system to keep up with the changes. So the claims and those denials are increasing, creating frustration for everyone.
Yeah, and not only does that obviously make it harder for a system to work, but think about all the smaller entities that deliver healthcare. It's a barrier to even entry, because immediately you would think an insured patient is a payer so that they can run their business, but then you have to consider how much it costs to be able to accurately accept and process those claims, which is becoming a whole nother thing. So it's not surprising to me at all that there's sentiment. It was surprising to me, the level of sentiment. I thought a pretty, from a layman's perspective, a pretty obvious murder case would be met with complete condemnation.
Absolutely.
But I think last I looked, there was like GoFundMe stuff in the tune of $600,000-$700,000 to support that alleged, criminal event. So I don't know, is there anything from the health system standpoint in the United States, or, in general with public health policy, where, it gets obviously very multifaceted. How do we get past where we're at as really a country when it comes to the insurance situation?
And I think you've identified the real issue. The public sentiment is just, an indicator that we need to do something different and better. We and we need to do something different and better on the insurance company side, but we also need to do something different and better on the healthcare delivery side. We need to work together to solve this problem. And, I find myself having conversations with lawmakers. I find myself having conversations at the federal level. Are there things we can do to make it easier for people? Can we make the pre-authorization process simple? Meaning if a healthcare organization has been working with an insurance company and every time we call, they pre-authorize the imaging test or they pre-authorize the surgery because we've prepared and provided the right information correctly every single time, well, maybe we can get a status level of we call it gold carding, where maybe we don't have to make those calls anymore because we've performed at a level that meets the quality perspectives that the insurance company has put in place. Maybe there's some collaboration that we can solve some of these things. And I think we need to use public sentiment as a gauge for what we need to do going forward.
Absolutely. And it's impressive that, I think, and I'll say, to be fair, many clinics do this, but I know that in our ambulatory departments, we have folks that, like, their job is to advocate that when a physician puts in an order, that the insurance company delivers it.
Yes.
And, personally, having been involved in that space for many years, those folks are lifesavers. And for the system, it's a costly thing, but it shows that we do care about the community, and it's critical.
And I think you're right. At Monument Health, we've taken the philosophy that when one of our physicians puts in an order for a test or a treatment or anything, a drug, a prescription, that it's medically necessity. There's medically necessity background. They have the justification, the clinical justification for ordering that test, that treatment, that drug. And in our organization, anything that we consider to be medically necessary, then we provide that care.
Yes.
we provide that care whether or not the person even has the ability to pay for the care, because that's our mission. And so we've tried to reduce that friction, that confusion. Well, my doctor ordered it, but I can't get it now. And so we've taken a position on this internally that we're not going to confuse people. And typically, if it's something that isn't medically necessary for that person, the physician wouldn't order it anyway.
Right.
And so we support our doctors.
Yes, and that's wonderful. I know historically, I think it's been mentioned before, and for various reasons, maybe it wasn't the right idea. Has there been talk of an integrated health plan, something that would be more vertical, where Monument has its own type of insurance? What are the thoughts of that? I mean, that's a big undertaking. I don't know if it's practical. Yeah. What's the feelings about that?
I would say, we have a strategic plan at Monument Health, and the strategic plan, it's multi-year. It's currently a 5-year plan. And one of the areas that we continue to look at every year is how do we, as I said, reduce friction? Is there a way to not only be the healthcare provider, provide the services, but also be the healthcare insurer, where we have the insurance plan that's integrated with our organization? And we've looked at this over the past 3 or 4 years, and what we've tried to do is balance how do you run an insurance plan and deliver care at the same time. And when you're in the insurance plan business, the population that you serve is important. You have to have what we call them covered lives in an insurance plan. The more covered lives you have, the more successful you can be running an insurance plan. And so, unfortunately, Western South Dakota isn't as highly populated as many other parts of the country. So every time we get close to starting an insurance plan or doing something, we realize that until our population grows a little bit more, we can assume more risk. We can assume we can run a business better if we have more people, and we're just not there yet.
That's interesting. So maybe something in the future.
In the future, and I would say we have conversations frequently with other insurance companies to say, how could we work together?
Sure. What
would that look like? We have those often, and we will continue to have those until we're sure that we can run a well-ran insurance plan here for our community.
Yeah, that's an exciting prospect.
It really is.
And when you look at health systems in general, just kind of zoom out a little bit, I think it's become, the definition of them have become maybe a little bit frayed. It's not so clear exactly what a health system is anymore. How do you think of a health system?
I think a health system is a healthcare organization that, in my frame of mind, provides a continuum of care. And so, what do I mean by a continuum of care? Some organizations are just hospitals. They provide care in their hospital. Well, a health system looks at all the places you can get care and receive care. For example, we have a home care division, so we can provide care in the home. We have nurses that go into patients' homes. They bring medicines. They bring durable medical equipment. If you need, if you're recovering from, say, a surgery, we have nurses that will care for you at home. Well, then you look at other types and locations of care. We have urgent care locations throughout the region. We have ambulatory outpatient physician practices throughout the region. We have our hospitals, but we have our emergency departments. We have our hospice programs in the home. We have hospice programs in our hospice houses or in our hospitals. We provide care from the beginning of life with our labor and delivery programs to end of life, in our intensive care units and our hospice programs. So if you think about everything that we do in Monument Health and for the region, it's a system of care. And once a patient's discharged from one of our hospitals, we're going to follow them. We're going to make sure they get an appointment to see their primary care physician. We're going to make sure if they need home care that we're there in their home. And frankly, if you think about it, I think it's the best way to provide care because you're providing the lowest cost care in the right setting.
Yes.
You shouldn't have to come into a hospital and get care for things you could get somewhere else and more convenient for you.
Exactly. And I think it's interesting that I think what some people might not appreciate is that within the spectrum of the health system that you're leading, it's really driven by the community needs, which maybe is a differential between like a for-profit versus a nonprofit. I mean, I'm not to say for-profits don't do that as well, but tell us about how you decide where to put the emphasis within the spectrum in Western South Dakota.
Yeah, and so you just said it. Monument Health, we're a not-for-profit. We're private, but we're a not-for-profit health system, meaning we take time to understand what the needs of the region, the healthcare needs of the region look like. Every 3 years, we put together what we refer to as our community benefit plan. We survey all of our communities, and we understand what some of the barriers are to positive health status. Is it diabetes? Is it obesity? Is it cancer? Is it mental health? What are the issues that those communities are facing? And then we put a plan together to address those community needs. And in many cases, we find we need to recruit different physicians, new physicians or specialists to our region, or we find we need to expand our clinics or buildings to support those needs, or frankly, just bring in a specialty or a service that we've never had in the region. And so it takes time to put our plans together, but it creates that North Star. It creates that vision for what we need to do to solve and improve care in our communities.
Yes, and that's perfect. And then I think what is also worth emphasizing is that we have boards from active community members that help guide that in addition to professional community assessments. Can you talk about the boards that kind of help you make the decisions on how to lead?
Yeah, so, at Monument Health, as you mentioned, I might be the CEO, but frankly, much of our focus and planning comes from insights from people that live in our communities. Many of our local community leaders take an active role, and they serve on one of our boards. So we have a governing board that I report to. I have 12 bosses, and they're wonderful and they're amazing people. And then within our system board, we have additional boards. We have a board representing all of Rapid City. We have a board that represents everything outside of Rapid City that includes Custer and Spearfish and Wall and Hot Springs and Sturgis. And then we have advisory boards. Each of our communities have individuals that serve on our advisory boards. And we really take time to listen. We'll bring things to our boards for discussion, asking them for direction, asking them to help us weigh in on our performance and areas that we need to improve. And our boards really do a great job making sure we're elevating our quality outcomes, our patient experience outcomes. They want the culture of the organization to continue to grow and improve. They want Monument Health to be a great place to work because in our communities, we have an economic impact as well.
Yes.
So all of the people that are, and I have to mention, everyone that serves on one of our boards or advisory boards are volunteers. No one's paid to serve on our boards, which makes their impact even more incredible because they're there because they support the organization, but they're there because they want Western South Dakota to thrive.
Yes. And it's impressive the few times that I've had brief interactions with the board and various other advisory groups. The depth of the professionals there is pretty deep, and it also strikes me that there's really quite a lot of influence. And as from the community standpoint, it's wonderful to have those voices heard and cared for. You touched on this, and I'm interested in kind of how you see Monument Health from an economic standpoint in the city, because obviously it's a huge employer, and I think other organizations look to how Monument does things, and there's a lot of modeling. And it rolls outside of healthcare. It kind of rolls into more corporate management style. Do you think about those decisions much and how they relate to that? Do you think about the employment status and the city economics? Does that cross your mind much?
I spent a lot of time in this space. I think when you're serving in an organization as a leader, that you're also responsible. You have a civic duty to pay attention to how not only your organization impacts the region, but what are you doing to improve your community? And Monument Health serves many communities, and so we have great responsibility in ensuring that we're growing in all of our communities the right way. And we are the largest employer in Western South Dakota. Our annual payroll is probably around $550 million a year. That payroll has a ripple effect.
Yes.
I would say it. When you look at the statistics, we have around 6,000 employees within our organization, but based on the payroll, we probably create another 11,000 jobs in the region, and probably another $811 million in economic impact.
Yes.
So as any business in our community that creates jobs, creates that economic impact, we have a responsibility because our communities have grown to depend on even the tax base. I think we paid about $45 million last year in taxes.
Yes.
And so it's important, it's basically an outcome of the good work we do in our organization. It's an outcome of the good work that our caregivers and physicians provide, but it's still an outcome that I pay attention to.
Wonderful. And I think it's also worth noting there's been, and you'll know this far better than me, but there's been concerted efforts to train certain workforces, I think nursing in particular. And I know there's been various partnerships over the years. Is there anything that stood out to you where you developed certain areas of workforce for the community?
Well, a few years ago, I was asked to participate on Senate Bill 55. It was a task force. Yeah, so exciting. It was 18 months of really learning and understanding more about our university system across the state. And the task was to look at tuition rates, look at how do we create a more efficient system, and we all have to do that sometimes in our businesses. Well, we looked at the university systems, the regential system, just the same way. One of the elements that came out of that work, there were quite a few recommendations, but one of the elements that we came to understand is that we're producing nurses, we're educating people, they're obtaining their education and clinical training in nursing, but we don't have enough. We just don't have enough nurses to support the needs in our state. And that prompted us to really sit down and say, what are we going to do? How do we fix this? And I'm really excited because one of the solutions is happening here in West River. And we've partnered, Monument Health has partnered with Black Hills State University and South Dakota State University to expand the nursing program here in Rapid City. And so it took money from our state, our lawmakers, from Monument Health and others, and we are building an addition onto the Black Hills State University campus here in Rapid City. We're going to grow the number of students in that nursing program from about 70 nurses a year to 120.
Good.
And so those are 4-year, bachelor's prepared nurses that hopefully they'll work at Monument Health, but they can work anywhere in the region. Our nursing homes need nurses. Our physician practices, the VA needs nurses. Indian Health Services needs nurses. So I'm really excited that something that we started through just studying the issues several years ago are actually this fall are really going to happen with this nursing program.
It's so exciting. And if you talk about ripple effect, that has a wonderful positive outcome just down the road.
And it's so unique because it's a public-private initiative that will care for this region for generations to come.
Yes, it's beautiful. And I think the other area that's worth noting is the foundation and the work it does. It's really easy to look at Monument Health and they say it's the hospital, which is obviously a critical and huge part of a health system. But there's a lot of other pieces beyond just the development of the community, as you just spoke.
Yeah.
But the foundation takes it kind of a step further. Tell me about that.
Well, this is where I call it generous people really show their care, their concern for the region, and they gift us with money, they gift us with services. So Monument Health has a foundation, which is part of our organization, and every year we receive financial gifts. Many times it's from grateful patients, grateful families, and what we do with those gifts, sometimes those gifts are directed at a specific area. Maybe a family had an experience, maybe they had a baby come too soon, and their baby was in our neonatal intensive care unit for weeks or months. Many times we'll receive a gift from a family, and it's a financial gift. Perhaps they want to help buy some new equipment because they saw, an area where we could have used some more items, or they experienced something or asked us, what could you use? And so many times it's a person in our hospice program that experienced a family member passing away, and they want to make a gift in memory of that individual. So every day, every month, every year, we receive gifts. And once we receive a gift, 100% of that gift is used within the organization. Many times they have a directed idea where they want the money spent. Sometimes they just say greatest need, whatever you need. And I would say year over year we're seeing those gifts increase, and we're so grateful. We received, actually last week, we received a $2 million grant from the Helmsley Charitable Trust to support our neonatal intensive care unit. And fortunately, we were able to buy quite a bit of new equipment in that area. And we're just so excited about gifts like that.
Yes.
And I think we wouldn't receive gifts from individuals or organizations if they didn't truly believe in what we were doing and how we're helping the community. And it's my goal to continue to share what we're doing and keep those lines of communication open. Where we can help, we want to help, and if you want to be part of it, please let us know.
Right, and I think it shoots back to having faith in the organization, which goes back to governance. Yeah. And people can say, hey, not only do we have a C-suite that's leading in a thoughtful manner, but they're being guided by boards of volunteers that have deep insight to try to direct policy. And then, as you know, a health system can be optimized forever. There are 1,000 different levers you can push to make certain things better, but there's only so many resources.
Right.
So when people feel passionate about something, they now have a mechanism through the foundation to say, I would like to see this sector of the system better, more resourced, and so they give a gift. And I think it speaks to, I think that's a wonderful thing to have as a receptive as an organization to take that and apply it. And I think it's wonderful that they have the faith that it would be managed well.
Yeah, and it's an honor. When we receive a gift, it's an honor to use the gift in the way that people have a vision for, and we're responsible. We want to do the right thing. And I think part of receiving the gifts that we've received is also what we do with all of our resources in the community. For example, last year we provided over $127 million in, I'm going to call it community benefit, because that's how we have to account for it, meaning we provided free care to people all over Western South Dakota. As I mentioned earlier, if a physician writes an order for a medicine or a treatment or a test, if that person cannot pay for that service under our charitable care policy, they don't have to pay. And so last year we provided over $127 million combination of free care, and there are some not-for-profit organizations in the region we also provide with sponsorships, because we know without those dollars they couldn't support the food banks. They couldn't support some of the housing needs or the transportation needs of the community, and we know how important that is. So our community benefit, the work that we do to impact our communities that way, is part of our mission.
Yes.
And we're going to continue investing in our communities the same way. And I think when we do that, gifts come back to us. And, maybe they're small gifts, but they're still important.
Yes.
And our gratefulness for those gifts is immeasurable.
When I had a chance to talk to the mayor, I asked him right there, what is it that Monument Health can do for the community from his perspective? And to surmise, he said basically, be the best healthcare system you can.
Yeah.
Which made me think, it made me think about the partnership with Mayo Clinic.
Sure.
And I'm curious, as it's been a while now since that was done, I'm curious to hear your perspective on how that has gone.
Yeah, we've just celebrated our 5th anniversary.
Is it that long?
5 years,
Wow.
I know, as a member of the Mayo Clinic Care Network. And really what that is a formal clinical affiliation with Mayo Clinic. And, from just a family member or a community member's perspective, what you would mostly think about is if you're in one of our hospitals or clinics and you're seeing a physician and you have a diagnosis and or you're getting worked up for a potential diagnosis, if you want a second opinion with a Mayo Clinic expert, that's available to you for free. And it takes probably about a week. All your information, your medical information is forwarded to Mayo Clinic. And that specific subspecialist most likely will maybe reach out, talk to your doctor at Monument Health, read all your information, and about a week later you'll get a written second opinion that is provided. It's put in your medical record in our Epic system, and it's available. Your doctor here at Monument Health will review it with you, and you can make decisions about, do I need more testing? What's the right treatment? Should I stay at Monument or should I go somewhere else like Mayo? What we've seen since this relationship has been in place, more and more people stay close to home. And that's really why we have the relationship. My goal is to keep people closer to home, closer to their families, their jobs, their churches, their friends. And we've seen that. And then they have this peace of mind with that second opinion.
Yes.
They have something to refer to later as well. And, that's one element of the relationship with Mayo Clinic. The other elements are not what people would necessarily see. Internally, we have we have all of their policies, all of their procedures available to us, so we can improve our organization based on their experience. We have been on a path to improve our quality outcomes. Mayo Clinic has been helping us with that over the past 5 years. In fact, we were just notified last week that our star rating with the Centers for Medicare and Medicaid for the Rapid City Hospital is now a 4-star rating. Yeah,
awesome.
I mean, that's like applause.
Yes.
4-star rating, which there isn't another tertiary level hospital in South Dakota with a 4-star rating. And our goal is a 5-star rating. So we are one star away. And so that's been a lot of work to get to that 4-star rating. I have to credit our caregivers and our physicians for achieving that level of performance. But Mayo Clinic has been working, at our elbow for the last 5 years to help us get there.
That's wonderful.
And so, that's another element of the relationship. I think another more important element is that all the clinical algorithms, the clinical
yes.
protocols that Mayo Clinic has in place are available to all of our physicians.
Yes.
And they're available. You can, most of our physicians, as you know, Dr. Tamang, you can download those algorithms, or you can look at them on your phone, or you can pick up the phone and talk to another Mayo Clinic physician.
Yes.
So it's, we've greased the skids as far as helping our physicians have as much the best information available to them, so that they might be practicing in Western South Dakota, but frankly, they're getting world-class support to do their work.
Yes, and I think you would probably agree that most of the physicians that work for you, they tend to have a high degree of confidence in themselves.
They do.
But when I was fortunate enough to be working as a hospitalist, I found it very useful because Mayo Clinic has certain technological or tools and subspecialists that we do not have.
No.
And that would be normal of any community our size. So it was very useful within our EHR to be able to push a few buttons, and then the appropriate subspecialist at Mayo has access to that patient's chart.
Yeah.
And you have open communication. So it's a rarely needed issue from the common medical problems, but when you need it, you need it.
Yes.
And it was very helpful. And almost always, in my experience, and I think my colleagues' experience, it was no, you guys are doing everything right. If this happens, send them our way.
Yeah,
or,
reassurance.
Yeah, or get this stabilized, and then let's set up follow-up down the road so we can monitor these particular things. So from my perspective, and I think I would speak largely for the other physicians, it's very positive to have it. You kind of, in a way, want to make sure you've got your house fully in order, which I feel confident we do. But when those tertiary care resources at an academic institution are available, you want to be able to plug into them quickly.
Yeah. What we're seeing, I would say the most common second opinions are in areas, for example, a cancer diagnosis,
Yes.
neurological diagnosis, heart and vascular. Those are probably the top 3 areas where we see most of those second opinions.
It's really a nice resource to have. And then it also, and I don't think this is necessarily an advertised point or even part of the desired issue, but it also makes it easier if a patient does need to go to Mayo, they already have all the info.
Yeah.
So you don't have to start the process of referral from scratch. So and that time's important, if you have a hospitalized patient. So I think it's fantastic, and I think the community does appreciate it. You touched on this as well, but I'm curious, when you look at our health system and the surrounding health systems, how do you gauge quality? Because I feel like I'm a little cynical with all of the various quality metrics. Like I feel very confident that we have quality programs. How do you look at it and say, where's our scorecard? How are we doing compared to others? How do we know where we're going to make it the best we can be?
So it goes back to our governance. You mentioned it earlier on. We have a board committee. It's called our Clinical Practice Committee, We have physicians. We have mainly clinicians that serve on that board committee, and they evaluate and identify the quality metrics that we're going to hold ourselves against. We use those as called a benchmark. Everyone has benchmarks. We use outside benchmarks to compare our internal performance to other healthcare organizations across the country. And so our board committee literally sets the benchmarks and compares our performance to those benchmarks.
Wow, so that's internal.
It's internal, but we use external data to compare ourselves to. One of the areas that the committee, the clinical practice committee, adopted was the Center for Medicaid and Medicare star rating. And so when several years ago, when they identified that as a clear benchmark, a board-directed benchmark, we said our goal would be a 5-star rating. We started at a 1-star rating. So we've come a long way in a short period of time. Another benchmark that we chose, or our clinical practice committee chose, was a leapfrog safety grade. And so Leapfrog is an outside agency that looks at safety in hospitals primarily. And the highest grade you can achieve is a grade, a Leapfrog A safety grade. Just I should mention, Mayo Clinic is a CMS 5-star hospital and a Leapfrog has a Leapfrog A safety grade. And so today, Monument Health in Rapid City, for example, has a Leapfrog safety grade of a B, and our goal is an A. And so I'm hopeful maybe next year we'll be at the A level. But, so it's that clinical practice committee, it's that governing board that really sets some of those goals and benchmarks. Yes. And then on a routine basis, our governing boards actually, every board meeting, look at quality metrics, how we compare with our benchmarks, and they kind of do a deep dive, I would call it more, and they look at multiple specific areas. For example, what does our infection rates look like after surgical procedures? What kind of harmful events are happening or are not happening in hospitals? And so they look at probably 90 different factors in how we're measuring and monitoring quality. Yes. And our boards, they understand our hospitals are caring for not only them and their families, but all of our communities, and they take great responsibility for those quality outcomes.
Yes. As a physician, I'm very happy to see a higher star rating. I'm happy to see a Leapfrog rating that's good. Realistically, when I'm in the hospital, I have faith in the people that are attempting to care for our community. So from my perspective, I often wonder, and I'd be interested in your thoughts, how close are these known benchmarks, because I would assume there are proxies to quality, how close are they to actual quality of what a patient would receive, in your opinion?
I think we could all argue why something that we're doing, I would say every caregiver, every physician in our organization works to the best of their ability, and I would call it positive intent. Yes. They are there to do one thing, make a difference. And that's our mission statement, to make a difference every day. Yes. And they're there doing their best. But when you look at medicine today, it is delivering care today is complex. And delivering care in an organization where there's thousands of people creates complexity. It starts from the simple things like infection control. How is the room cleaned before the patient was brought into the room, the operating room, the inpatient room, the procedure room? How are the instruments prepared? What does the infection control practices look like throughout the organization. So that's one piece. But then you've got someone preparing medications in the pharmacy. You've got another person drawing lab work and getting those labs processed in a timely manner. You have surgical technicians, you have nurses, you have medical assistants, you have respiratory therapists, you have physical therapists. You have thousands of people focused on one patient, and there isn't room for mistakes.
Right.
And what we really focus on in healthcare is process. And our performance improvement is focused on process. What happens every step of the way to ensure the best possible outcome? And so, I was initially going to say everyone in our organization is there to do their best, and we train them to be their best. What we do to focus on improvement is focus on process.
Yes.
How were the instruments disinfected? What did that procedure look like? Can we improve that procedure? And so, people are so important. We love our people, but for us to improve, we focus on process. And who doesn't want to get better?
Right.
Who doesn't want to make sure that patient leaves and they recover quickly and they don't have any harmful effects of being in one of our organizations?
Yes.
And so that's really how we're improving. And if we can attract great people that we want to be part of that, we only get better.
For sure. And I feel like that's the benefit of scale.
Yes.
You've got a pretty big platform to get data from. Connections with Mayo Clinic helps you scale in a seamless way there too.
Yeah.
And I'm very proud that we're moving up. And I feel like that has a lot to do. You have to have some kind of benchmark to put everybody in. And it's not always going to be perfect. It will never be perfect,
yes.
actually.
Yeah.
There'll be some things that are arbitrary. Our hospitals are not the same as a hospital in New York City. But yet the scaling system arguably is kind of trying to pigeonhole each one. But overall, wonderful to see things moving in the direction that any scorecard we obviously want to do well on. How does it affect reimbursement with CMS? How important are those from that standpoint?
Well, there's a program called value-based purchasing, and this is through the Center for Medicare and Medicaid. And the program, it's been in place for quite a few years now. And Medicare, Center for Medicare and Medicaid, they look at your patient experience feedback. They look at the survey data after a patient's been cared for and they complete a survey. They compare that survey feedback to all the surveys across the country, and they use that and give you a weighting in the program. They also look at the clinical outcomes, and they have a subset of clinical outcomes they look at and compare your outcomes against those of other health systems in the country. And then they look at a few other elements. It's more complicated than I can probably describe right now, but there's several hundred elements to the value-based purchasing. It's a big deal.
Yeah.
And then your reimbursement, it's a zero-sum game.
Can't ignore it.
So if your health system's doing better than other health systems or hospitals, you'll get reimbursed more.
Right.
And then if your health system is doing worse than, say, 50% of the other hospitals or health systems, you will be fined. And the money that you're fined, you pay in the fines, really pays for the benefit to the other hospitals that are doing better.
Salt in the wound.
Yes.
Yeah.
So what I could say is we're doing quite well.
Excellent.
In the value-based purchasing program because of the performance over this past several years and what we're doing with patient experience, and our clinical outcomes. We're on the positive side of that value-based purchasing window.
Excellent.
Yeah.
As time goes on, there's various, I don't know what the right word is, threats to the marketplace. And the one that's on my mind, and I think a lot of people, is Medicaid right now. I know there's changes with HHS and there's discussion of Medicaid at the state level and, of course, the federal level. That worries me because a huge percentage of the folks that we take care of depend on that coverage. And I'm interested in your thoughts on what you've seen from the Medicaid expansion piece and what you feel about the current threats. If that's probably not the right word, you'll come up with something more elegant, but and what we're trying to do to make sure we protect everyone in the community the best we can.
Sure. It is an interesting time, absolutely. And I applaud those in our federal government that are looking at how do we balance a budget, how do we run our country efficiently, making good decisions. So I support the philosophy around that approach. One of the areas that is being looked at is, where do we cut our budgets? I've heard, just as everyone else has heard, that Medicare won't be touched, that which is wonderful for those who are depending on their Medicare insurance. But there's a question about Medicaid. Today, about 80 million people, almost 80 million people are covered under Medicaid in the United States. And in rural communities, about 1 in 5 people have Medicaid. And they're depending on Medicaid to get access to see a doctor.
Yes, or pay for their meds.
Or to pay for their medications.
Yeah, that's huge.
And sometimes people get Medicaid mixed up with food stamps. It's not food stamps. It's just providing access to get care, medical care, medicines. And some Medicaid plans do pay for some transportation, getting people to and from their doctor.
Yep.
And so the concern is if budget cuts come on the federal level and cut the Medicaid program, that people will lose health coverage.
Yes.
And it could be a lot of people. It would be millions of people. And then there's another segment of, I'm going to call it traditional Medicaid. Traditional Medicaid typically covers pregnant women, elderly, those that are disabled and blind. But Medicaid expansion does cover probably another 20 million people.
Poverty-based, yeah.
Yes, and most of those people, I would say 60%, 67% of those people are the working poor.
Yes.
They have jobs. They just don't earn enough to cover housing, childcare,
Right.
transportation, all the things that we need, in our household budgets. So they can get health care. And from my perspective, that does keep people working. I mean, if they can see a doctor and they have access to medications and drugs and they can stay healthier, hopefully they can stay in the workforce because we know we need people working.
Yeah, and so from my perspective, we, Monument Health, will see you whether you have Medicaid or not. We'll see you whether you can pay or not. The problem is after that doctor visit and you've been prescribed X number of medications, or maybe we're sending you for specialty care somewhere, you could think a lot of physical therapy or speech, they have to keep their doors open. If you don't have coverage, those things are not available. And there's a lot of people that are very concerned that could go away. And so I'm curious, is there anything we can do or is there anything we are doing to prepare for that eventuality? Or is that on the radar at this point? Are we too far from that?
Yeah, I think there's going to be some difficult decisions coming out of Washington, D.C. What I can tell you is, I have great relationships with our congressional delegation. We inform them of the impacts that could happen in Western South Dakota if, for example, if South Dakota loses or the federal budget is reduced and the state of South Dakota doesn't have the federal funding to support the Medicaid program, what those impacts could mean.
Yes.
Who wouldn't have access to care? Who would be relying on the emergency department
That's what happens.
as their primary care physician, which it's a busy place already.
Yeah.
I don't think it's the appropriate place for people to see their primary care physician.
Yes.
So we're maintaining an open dialogue. We're talking about the potential negative implications and impacts to our families and our communities. I think just educating, letting them know the potential impacts so that they can make good decisions is important. And those dialogues are happening daily and weekly.
Yes.
Yeah.
And talking about it's really important.
Yes.
Even in forms like this. It's interesting to note, too, that Medicaid as a payer historically, and I think this is quite public knowledge, is no one's getting rich off billing Medicaid. It's it's a typical loss for the organization that has seen a Medicaid patient. But it's not an absolute loss. And that means that people, most organizations, again, following the lead of kind of the larger groups like us, I think they say, well, we should take Medicaid because it's the responsible thing to do. And I think a lot of people on the individual level, when they have Medicaid, they feel more secure, and they should. But they feel like they're not going to get some giant medical bill because of the way our particular insurance company requires us to do various invoicing, which obviously there's charity care and things get written off. But it's still scary when you see how much a hospital bill costs. And so having some degree of coverage, I think psychologically helps patients to a degree, even much more so than monetarily in many situations. So it will be interesting to see how things develop. And Medicaid has some very interesting programs. You named a few of them. But I think that at the state level with Medicaid, they have the Medicaid Health Home. They support community health workers and people that are out on the ground trying to reduce really high levels of inappropriate utilization to make the whole community better. So when Medicaid cuts get discussed, I think thoughtful is probably the least aggressive term I can use for that. It's just critically important that those folks get taken care of one way or another.
Yeah, it has an enormous ripple effect.
Yes.
It really does. Because, I think what we're seeing in Western South Dakota is more and more people from different agencies, different organizations working together to solve some longstanding issues. Mm-hmm. And as you said, Medicaid doesn't cover the cost. In most cases, Medicare doesn't cover the cost of anything we're doing.
Right.
But it does help. The dollars that we do see, we can pass on to some hard-to-recruit nurses and case managers and people that are really making a difference.
Yes. I'm interested in your thoughts as time is moving along and we're seeing trends happening in the private sector, in the ambulatory and in the inpatient side, but in particular, ambulatory disruptors. You see, CVS coming up with a bunch of clinics, Amazon having it. So these big, giant companies, massive groups. Do you see that as a positive, a negative, interesting, something to observe? What's your general feeling on these?
Well, I think we have a great country. And one of the best parts of our country is the ability to look at free enterprise and capitalism. And, it's what makes us special in the United States. Well, that same part that makes us special also attracts people that are in business that are thinking, well, maybe I could make an income off of doing this particular type of healthcare service. And so there are for-profit organizations that focus on just bits and I call them bits and pieces, yes, or fragments of the healthcare continuum where you probably can make a positive bottom line. There are some of those services out there that Monument Health provides, but there's quite a few services that we provide that we have a negative bottom line.
Right.
And it's the services that we have a positive bottom line that covers the cost of those negative. For example, behavioral health. We operate a wonderful behavioral health hospital. It cares for the region. Last year, we lost around, I wouldn't say lost, we invested $6 million to keep that hospital open.
Yes.
And so when the companies come in and they just focus on one segment that makes money, it makes it pretty difficult for us to continue to do the things that we were doing in the same way if they're taking that from our ability to care for the other areas.
Yes, that kind of goes back to being a full spectrum of care for the community.
Yeah.
And fiscal responsibility is kind of the overarching thing to make sure we can plug all those holes.
Exactly.
So it will be interesting. I think I'm excited to see how that could eventually push quality, because obviously they work hard to be innovative. It strikes me that a lot of these organizations struggle because the third-party payer system in the relation with health systems, it's a tough thing to get around, because most people, they invest a significant amount of their earned income into healthcare, and they want to use that. And those contracts don't necessarily make it easy for innovation to take place. When it comes to ambulatory care, are there any innovative trends that you're seeing that you're excited about down the road?
Yeah, you make me think of a few different things. I think getting back to insurance companies, and we all, those of us that have a commercial insurance plan, we're having to make decisions every year on, well, what kind of deductible do I want to pay?
Yeah.
And, those that pay higher deductibles have a lower premium. And so a lot of us have gone to a higher deductible plan, which then we're a little bit more choosy about, well, can I get lab services, for example, and what would it cost out of pocket for, I need to get some lab tests. Maybe I could just pay cash and get a price point, better price point. So one of the things that we've started at Monument Health to address some of that demand, this is ambulatory services and its demand, we've created, we call it cash labs. We've reduced the I would say the cost of those tests so people can come in those high deductible plans especially, but they can just pay cash.
Yeah.
And it can go toward their deductible, and they feel like it's competitive. It's creating a new demand for us, and we're responding with a better approach to meeting customer needs.
That's wonderful. Yeah. And so that becomes more of a direct relationship at that point.
Yes.
Two-party payer system, I guess. That's
Yeah, maybe. Maybe.
So in certain circumstances, that is excellent. On the hospital front, there's a lot of interesting things happening. I feel like AI is being talked about everywhere, but there's also some kind of old school ideas coming back, hospital at home.
Yeah.
And so I'm curious as to your thought on hospital development.
Well, got a lot of thoughts there. I would say I could look into my email every day, and there's probably 20 vendors trying to meet with me to share their latest artificial intelligence software and sell it to us. We're looking at artificial intelligence in our hospitals, in our clinics very carefully. We've recently introduced something called a bridge, and that's the name of a software, and it helps our doctors. Many times if you're coming in to see one of our doctors in the clinics, for example, or in their doctor's office, in the past you've seen them typing the information about you into the electronic health record. Well, they're looking at a monitor and they're typing on a keyboard, and then they turn and talk to you, and then they turn back. Well, this new software it's called ambient listening. So it's listening it's listening to everything that's happening in the room, and the doctor doesn't have to type the information anymore. It's automatically going into the electronic health record. So that's artificial intelligence that we feel is important. It's making our work for our doctors easier. They're capturing all the information, and it's improved the patient-physician, relationship in the exam room. But there are other types of artificial intelligence or software that we don't see a use for, and we're going to wait until some of these maybe novel ideas are tested.
Yep.
So we're going to introduce AI that makes sense,
Yes.
that improves efficiency, creates better outcomes, but we're not going to experiment. So that's my comment on artificial intelligence.
What's your feeling on where it's going to end up? Do you think, and I know this is tough, but do you think that it's going to get to the point where a patient can walk in and the artificial intelligence is doing the majority of the thinking and somebody approves it? Do you think we're going to get there, and do you think there's a time frame for that?
I don't think we're ever going to totally remove the human,
Yes.
the physician from the formula, the best formula.
Hopefully not.
I do think there will be information or tech, just the technology will help physicians make better decisions.
Yes.
They'll review, they'll use data, they'll use facts. It'll help the doctor evaluate a situation or a condition.
Yeah.
Give them more to consider, but it won't take, that human critical thinking out of the picture. That's my perspective.
Yeah.
I probably know too much to, but is Watson going to, is everyone going to have a Watson computer in their home and they're going to use that to be their doctor? I don't know.
It's really interesting when you play with these AI models, and they have them now specifically for medical knowledge. There is no physician that's even close. You could feed it every board from every subspecialty, and it'll crush them all.
Yeah.
It obviously it can't contextualize the problems. And reading about this, if it can find a way to contextualize those problems, obviously it would be amazing. But like you said, there's a lot of salesmen with AI solutions right now, and so thoughtful development, I think, makes sense. Have you given thought, or has it been has it been evaluated, the idea of hospital at home, or is that something that are still being waited on?
We've considered it several times during COVID, during the pandemic. Mm-hmm. We had at any one point in time 150 to 200 people we were checking on that were in their home and recovering. We had nurses following up on them daily, getting their oxygen saturation levels, making sure they were drinking fluids. If they were doing poorly, we'd bring them back into the hospital. And so we considered a hospital at home, 5 years ago, if you think about it. The challenge in Western South Dakota is scaling that. We do have home care, and we do have nurses going into the home. And the other problem we found during the pandemic is just bandwidth with telephone availability or internet availability, and some people still have flip phones.
Yeah.
And so you can't always get, in a hospital at home, you have to have equipment monitoring patients, and that equipment has to communicate back to a central location. And if you can't monitor people, it would be unsafe to run a hospital in a home. Maybe more of a urban setting would work, but we have trouble with that.
That's an interesting point too. How do you consider Rapid City? I know there's the technical definition, but in my mind, it's always kind of rural urban. It's kind of a mix.
Yes.
Is that how you see it as well? Absolutely.
I would say, in Rapid City, if you're in the hospital at the hospital here, 80% of our patients are from probably an hour, 2 hours away. Mm-hmm. 20% are beyond the two-hour distance.
Yeah.
So we do have that mix of urban and then pretty rural.
Yeah. Oh, yeah, very much so.
Yeah.
So that's interesting with a solution like hospital at home. You can kind of look at all these various ideas and, you have to figure out if it plugs into your community. So it sounds like it's kind of there, but maybe not, maybe something to continue to think about. Is that kind of where you're...
Exactly.
Yeah.
I mean, where can we scale it? Where can we touch the greatest number of people with the resources that we have?
Exactly. The other aspect I wanted to talk with you about is where a health system intersects with public health. This is particularly important for us, I think, because we are really the health system in this area. And there's a whole bunch of topics that are very interesting within public health, but I think the two that really affect Monument, that kind of, if you had a Venn diagram up where they would intersect, I think Native American health disparities is a big piece, probably arguably the biggest. And then mental health. It pains me not to talk about homelessness, but we'll stick to those two. When it comes to Native American health disparities, I had a great conversation with several people from Oyate and others, and when you look at the statistics, it's extremely discouraging. The degree of poverty, the degree of bad health outcomes. It is encouraging that things have gotten better, but nowhere near where they ought to be. How do you think about those disparities within our community?
I think it goes back to, it stems from poverty. It stems from children not prepared to go to kindergarten, children that have experienced trauma, and just leads to other issues, not graduating high school, homelessness, and so on. And so, and I'm, I'm passionate about this topic. There's so many great people in our community, in our region, that also are concerned about this. And, at Monument Health, our goal is to ensure consistent, high-quality outcomes for everyone that we care for. And so we pay attention to every person that comes into our doors. But clearly, when we look at our outcomes and making sure that there's equitable outcomes, it's our Native American people that return to the hospital more frequently compared to other non-Native Americans. And so how do we help them? How do we get them those resources? And so we've been working on this. As you mentioned, we've been working on it. It's going to take more time, more resources to connect with folks. The people that are making great strides doing this work in this community are remarkable. I work with several of these people at Oyate, Indian Health Services, Rural American Initiatives. I think we just all have to continue to talk about the issues and bring things to light so we can create the solutions. In June, Monument Health hosts what we refer to as our Lakota Lands Identity and Health Equity Seminar. We take 3 days, and we take 50 people on a education trip through the Black Hills, and we learn about Lakota history, Lakota culture, Lakota challenges. And then we take a third day and we dive into the healthcare disparities. And we've got great speakers this year, subject matter experts. And we talk about the gains, the things that are improving, but we also focus on the things that we have yet to improve and try and create those solutions. And so this is, Monument Health, as we focus on healthcare disparities, this is probably our number one area that we're focused on.
It makes sense because, from my understanding, roughly 8 to 10% of the population identifies as Native American, but the amount of healthcare issues and,
Yes.
Advanced stage diseases in relation to prevention, unfortunately, a huge amount falls on them.
Great disparities.
Yes. And so that's something that is exciting to work on because I feel like we can move the needle there. And one area that I think is interesting to talk about is sort of cultural-based treatments. this is something that I developed in myself because I am very much Western medicine orientated. I believe in the DSM. I believe in, your ICD codes. I believe in the algorithms that I've learned. But over time, having cared for a lot of patients who are Native American, I understand that sometimes those particular diagnoses and those particular treatment algorithms are less effective in certain cultural groups. You would not have been able to convince me of that out of medical school. I wouldn't have believed it. But I've now learned that actually there's huge merit to it. And so when we see a lot of these smaller organizations step into the health, I don't want to use quotations, but a lot of us would look at that. That's not healthcare. But really, the sweats and the ceremonial, processes and the things that they value in their healing medicine, it's something that I think as an organization we ought to embrace. And I think we have largely. Have you seen the role of that, or how do you see the role of more traditional Native American medicine within our organization?
I think it's important. I think it's important in anyone's background, if they're getting health care, to have holistic care.
Yes.
And holistic care to one person might look a little different to another person. I would say, at Monument Health, we've looked at, what does holistic care look like for our Native American patients. One of the things that we realized a long time ago was that smudging was important.
Yes.
And so, we necessarily in the hospital didn't have the right environment for smudging. So smudging is when you basically light sage with a match, and it burns, and it creates smoke. Well, what does smoke do in a hospital? It creates havoc.
Those CMS stars might not like that.
Smoke alarms go off, the fire department comes, and everyone has to evacuate. We don't want to do that.
Yeah.
So we created a process where, for that moment, if we wanted a patient or their family to smudge and have ceremony, we would turn off the fire alarms in that room. And we still do it today. And so we found workarounds to get to make sure we have a safe environment, but that people can have a ceremony, and they can smudge, and they can honor each other and pray. One thing we did to get a little ahead of the game, in the Rapid City Hospital, we built in the new addition, and it's a beautiful room, but we built a circular shaped room, probably seats around 15 people, and it has the technology, the smoke, I don't know, whatever you need, the ventilation system that we can smudge in the room, pray, and the fire alarms will not go off.
Yes.
So we made investments in our space to be more culturally appropriate for many of our patients.
Yeah, and I think it's represented in some of the more subtle things too. I think artwork around the hospital, and I think there's been a concerted attempt to try to incorporate wherever possible. And I think for anyone on the medical side that's listening to, there's been an emergence of sort of these cultural bound syndromes as well, which Western medicine doesn't look at. It doesn't see those, but based on very significant education and cultural teachings, has really profound effects on someone's mental and in some cases physical health. So being mindful of that is not, it's not virtue signaling. It's being virtuous. And so I'm happy that, and I'm proud of our organization for taking that seriously. When I look at historically, I think Monument Health's, one of the things that we've really tried to focus on is caregiver, provider engagement. That's been a piece that I think has been something that I've worked for Monument for over a decade, and I think I've heard that reiterated on pretty much the entire time I've been here. How do you think we're doing from that standpoint? How proud are people that work at Monument to be working for Monument, and how do we make that better?
I think this is, if there's one thing I would lose sleep on, it's how to be a great place to work. Meaning, how do we create an environment where people feel like they can be their best every day. They have a voice in what's happening around them. They feel like they belong. They feel connected. And, as I mentioned, we have around 6,000 employees working somewhere in Western South Dakota. Probably 80% of those folks work somewhere in Rapid City. And, everyone comes in a different place. Some are young people coming right out of school. Some are, 5 years into their career or their job. Some are, I'm still signing retirement cards. Last week, someone was retiring with 39 years of service. So we just have different people from different backgrounds. And so what we've tried to do is educate our caregivers on how important their differences are and talk about the differences and do it in a respectful way that they feel welcome. They feel that they have the ability to share ideas and contribute. How can we do something better? Well, tell me more. If someone works somewhere else in a different health system or a hospital, how did you do it there? I'd love to hear more. And so we take time. We have purposeful meetings with our caregivers to talk about differences. Talk about differences in age, talk about differences in backgrounds, talk about differences in just where you're from. And I think it's really opened up our organization. We have a mission statement to make a difference every day, but we have a vision statement that really guides us. And at Monument Health, our vision statement is, it starts with heart. Our vision is to be inclusive, to be a team, and to show we care, and to do the right thing every time. And so the vision to be inclusive, really, we've had to execute on that. How do we be inclusive? How do we bring our physicians to the table? In my role as the CEO, I approve things. I approve resources and budgets, but I don't approve anything until our physician leaders have had a chance to weigh in on things, and our nursing leaders and our overall leadership teams. And so, we have probably 350 people that represent supervisors, managers, leadership in the organization. And, they are really the day-to-day leaders in the organization. And so we have to have everybody aligned.
Takes a village.
It takes a village. And I think when you create alignment on our strategic plan and our mission and our vision, and we're all using the same words, you create an environment that people feel comfortable in and they want to stay part of.
Perfect. I had to give a little thought to the last question. And so I'm curious, at the end of your career, what's one thing you would hope you have accomplished that would make you the proudest?
Oh, there's so many things I'm so proud of already. At the end of my career, I will be most proud when I can look back and know that people in our region were not left behind, that they felt that they could get care, they could get compassionate care, and not have to leave to get that compassionate care, high-quality care.
Beautiful. Paulette, thank you for the conversation. I really enjoyed it.
Thank you.